Okay, welcome to wrap-up interview. This interview is entitled OCT in Clinical Practice. Here we have three specialists about OCT. May I introduce all of the experts from this side, Dr. Evelyn Regar, Dr. Soo-Jin Kang, and Dr. Giulio Guagliumi. As they know very well, OCT become very practical way in the clinical practice, and OCT move from research tool to the practical tools now. So today we discussed about the OCT guided PCI and OCT use in clinical practice. As you may know, after development of frequency domain OCT, it is quite easy to use an OCT in daily clinical practice. We can identify the position of the image by lens marker, and we can identify the region between the lens marker and proximal marker. And also, if we use another type of machine, we can clearly identify the position of the image by co-registration of OCT and angiography. Using this machine, we can compare the pre and post OFDI and post OFDI and follow-up OFDI by co-registration method, as you know very well. But there are still a lot of discussion about the advantage of IVAS and OCT in daily clinical practice. These experts knows very well. Resolution is higher in OCT. However, the penetration depth is shallow in OCT. The frame rate is higher in OCT, and therefore the playback rate is very fast in OCT. And using this method, we can clearly identify the product characteristics. It was already reported in consensus standard for acquisition measurement and reporting of intravascular OCT studies. And the prediction of the procedure complication is very important. There are several pilot studies, as you know. If you find a thin cap fiber ateroma at the site of culprit, and also the lipid arc is larger than more than 2 quadrant, there are high risk of no reflow or slow flow during PCI. And if there are a thin cap fiber ateroma at culprit site, there are a risk of microvascular obstruction after PCI. But these are only pilot study. There are no randomized prospective large-scale studies. And also using OFDI, we can identify the TICFR in after stent implantation. Also, the calcification or intimal rupture. These are the neoatherosclerosis within neointimal. It is very easy to identify the pathophysiology in neointimal after stent implantation. Also, Dr. Kang already reported there are several mechanisms about a late stent failure. As you know, in-stent restenosis or stent thrombosis is very frequent in case with stent failure. And if you find a lipid-laden tissue, such as neoatherosclerosis, might be the cause of these late stent failure. It is started very earlier compared with bare metal stent, and this is the MGH OCT registry. As you know, such kind of neoatherosclerosis start very earlier in DES compared with bare metal stent, as shown in this slide. And when you do the OCT at the time of intervention, we can clearly identify the reference lumen area and reference lumen diameter, and also minimum lumen area as shown in this slide, and easy to identify the length of the stent. Using the lumen profile in some machine, we can clearly identify MLA and the reference area and the length of stent as shown in this slide. And also after stenting, we can clearly identify the success of our procedure or some abnormal findings after stenting. This is one of the post-stenting abnormality evaluated by OCT. Stent incomplete apposition or tissue protrusion or dissection can be identified very easily. And there are, as I told you, several discussions about the advantage and disadvantage of IVUS and OCT. As I told you before, by IVUS we can get the whole lumen image and easy to identify the vessel size. But the detailed assessment of the plaque is very difficult by IVUS. However, using OCT, we can get a very high resolution image and the plaque type differentiation, and we can identify ThinCap fibroateroma, and after stenting, easy to identify the position or tissue coverage. But there are limitations of the poor penetration or some other limitations, as you know very well. So we have the pilot study data, but we have not enough data about the randomized prospective large scale of study. So today I would like to ask the specialist about the current consensus of standards and application of OCT and risk stratification by OCT, especially during PCI or after PCI, or role of OCT in stent failure. Or how about the OCT guided PCI compared with IVUS guided PCI? There are, I think, several advantages and pitfalls. That is today's focus. How about the first one, current consensus standard and application of OCT? Evelyn, you have some opinion?
OCT is a relatively new technology, and I think this is exactly the reason why it's so important that we start discussing standards, that we start to make sure that we are all over the world as OCT users talking the same language, that allows us to compare our results, that also allows us robust reporting of OCT results, and it makes sure that we all speak a common language which allows us to push the field forward. I think it's also important that during these discussions and the writing of this document, we also clearly identified issues where there is general consensus, where supported by good statistically powered data, but we also identified areas where there is clearly a huge need of further validation. And I think this is really important that today, when OCT is ready for widespread clinical use, we can provide the users also with some guidance on the interpretation of the findings, on the reporting of the findings, and also on the areas where we still need to be careful and where we need further data to interpret the images correctly.
Yes, Evelyn pointed out the very important things. We have to have the same understanding of the naming as well as the technique, as you said, right? So is it okay enough we have the communication when we use some interpretation or some word in daily clinical practice OCT use?
I think in your introductory talk you mentioned a number of areas where clearly we still have some work to do.
Right.
You mentioned the preclinical assessment of lesions, but also the post stent implantation assessment, and I think here we have a lot of data and knowledge from IVUS, but we still need to identify the role and optimal cutoff values for OCT. What is an optimal stent expansion, for instance, for OCT? We also have to establish further criteria. If you talk about risk stratification, we know for sure that OCT is, from all the tools that we have in clinical practice, the best to identify thin cap fibroadenoma. We also know that it allows us to identify lesion morphology very, very well. But again, we need to prove and to see what is the clinical impact of these findings, and how do we, and this is most important, how do we address them by adequate therapy.
Okay. At the moment, we have almost, how to say, consensus is not perfect, but nearly, I hope, the perfect, right? But relatively new technique, we still have new things, right? So at that time, we need much more discussion to get in a consensus. By the way, Dr. Kang, you did a lot of pilot study to show us the stent failure, right? Are there any advantage of OCT compared with IVUS in the assessment of stent failure, or other advantage in daily clinical practice?
The greatest advantage of OCT is derived from the excellent resolution. So some tissue characteristics within stent or any other structure that making the stent failure are well demonstrated by OCT, but not demonstrated by IVUS. For example, the lipidic area or the TICFA necrotic core and the small rupture, they are so frequent in the stent failure lesions by OCT, well demonstrated. However, the IVUS cannot shows the exact findings, and the agreement rate was only 50% for detecting the plaque rupture in our study. So the more accurate assessment of the stent failure, the underexpansion, intima hyperplasia, and what's the mechanism of the progression of the intima hyperplasia, then the rupture event, we have to use the OCT.
Right. So after stenting or follow-up after stenting, the OCT may have an advantage to identify the abnormality. I agree. And Giulio, you do the OCT-guided PCI in daily clinical practice, I think. Do you have some reason to use an OCT use compared with an IVUS?
Well, I think yes, because when we are approaching coronary arteries, we are approaching for making diagnosis and for making interventions. And we have to decide. And in making diagnosis, we think that there are clear advantages of OCT in terms of speed. So it's going to be very quick. So if your time is limited, and for instance, the patient is quite urgent or emergent, you can gain a lot in terms of a shortness of evaluation. So I think that, for instance, in high numbers of acute coronary syndromes, this could be an advantage for OCT. The second advantage is we are very practical. We are talking about a lumen. And except few countries, in almost all the countries in the world, the vast majority of the procedure are guided by angiography. And angiography means a lumen. We recognize that we can gain much more, but in any case, until now, the vast majority of the intervention are still using lumen as a reference. So OCT is very reliable for all types of segments, before stent level, after stent reference, for getting this precise measurement. And I think there are a lot of demonstration that with the current technology, that is not anymore the occlusive technology, the value are very near between IVUS and OCT.
Right.
And another advantage is that in terms of discriminating early versus advanced pathology, OCT is much more reproducible and much more thin. Means that you can get precise information about the intimal thickening. You can get precise information about calcifications and penetration in calcification and assessment how deep is the calcified tissue compared to the lumen. You might have as a unique possibility, the detection has been mentioned many times before, of a thin fibrous kappa atheroma, the entire spectrum of the rupture plaque, or the alternative, the plaque that were not ruptured, and perhaps in this case in combination with the functional techniques, you can make a precise decision not to intervene. So it's not only for guiding the intervention, but could be helpful in making decision at the different stages.
I see. I think there are some criticism about OCT in the penetration depths, right? Using OCT, we cannot get enough whole vessel images sometimes. Do you think is it a disadvantage of OCT in the daily clinical practice? Are there anyone can comment about? Yes, Dr. Kang, right?
Even though OCT has a good resolution,
right.
As you commented before, the OCT cannot show how large the vessel is and how much the plaque is. So the optimization in real practice, the most important the optimization criteria is IVUS, the stent area, and the plaque burden at the reference segment. But in the diffuse lesion, the OCT cannot show the information. So finally, it may be evaluated the lumen-based decision. So it has a risk for the undersizing of the stent relative to the IVUS. IVUS determined the vessel area oriented size. And we cannot have some information for the optimal landing site. So the two factors are the most important limitation of OCT, especially in the diffuse lesion.
So do you prefer to use an OCT for the guidance or IVUS?
Yeah, so in this regard, I prefer the IVUS guidance and the real the practice, the PCI procedure, during this procedure.
How about Giulio?
Well, I think we are talking about two techniques that were born in a completely different time. So IVUS had a lot of time for showing the potential advantages, and we are still interrogating which one they are, because in fact they are very weak data on study, except for few specific indications like left main disease, where IVUS was demonstrated quite crucial in having impact on outcome. OCT is very, very recent, so we cannot ask to have the same level of evidence today. I think that OCT has some more specific indication where, for instance, you have additional characteristics that cannot be catched by the IVUS, like a thrombus. We haven't discussed about the fact that thrombus is a problem for IVUS, is absolutely not a problem for OCT. So I think that the clinical context in which to use the two guidance procedure can be a little bit different. This is my personal opinion.
Right.
Giulio, I think from a more practical point of view, I think we should also not forget that OCT, with its fast data acquisition really allows us now to acquire a three-dimensional data set in a couple of seconds. And I think for practical reasons, this is really a game changer, because it means that you can interrogate patients with subtotal or very tight lesions. You can interrogate patients that are unstable, because the additional time that you need for your diagnostics is just a couple of seconds, and the amount of ischemia that you introduce is really minor. But on the other hand, you gain a three-dimensional data set, so you don't have the need to have 2 or 3 orthogonal angiographic projections, so you save time, and you have in one shot you have all the information. And in my experience, having a 3D data set also makes up for a lot of the shortcomings that OCT has in terms of penetration depth, in terms of determining the adventitia, because in 3D you can really, in a single glance, appreciate quite nicely the lesion morphology, and you can also get a good understanding about reference segments, about optimal landing zones. So I think that is another really important advantage of OCT that we see now with the new systems, the very fast systems coming and entering the clinical practice.
Yes, I agree. The 3D reconstruction is another advantage of OCT, and using this system, I'm not sure at the moment, but it might be useful in the guidance of PCI as well as in the follow-up identification of the abnormality in the coronary arteries. How about the prediction of the complication of the procedure during PCI by using OCT? Are there any comments?
Well, there are already many data showing that, for instance, the detection of thin fibrous kappa atheroma can be a risk factor for microvascular obstruction, for inducing periprocedural MI. We started to have some evidence that the landing zone of stents can be quite critical in dictating the response, the vascular response of the stent. And I think that in getting the malaposition, the gap is enormous between IVUS and OCT. So I think we can be very, very precise and to understand much better how to deal with these factors.
I see. The selection of landing zone is very important, and also the non-flow limiting vulnerable plaque identification is also very important to improve the patient prognosis. It's a very similar concept about the selection of landing zone and the prediction of the vulnerable plaque, especially non-flow limiting. Are there any possibility to get to predict the prognosis of the patient in case with non-flow limiting vulnerable plaque? Evelyn, do you have any data?
We don't have, at least to my knowledge, we don't have any prospectively validated data. But important, and this is in addition to what Giulio said, I think it is also important to realize that another light-based imaging technology, near spectroscopy, that specifically looks at necrotic core, when we look at these data, they show exactly the same results. So again, we have from different technologies just showing the same circumstantial evidence, if you want, that indeed thin cap fibroateroma, a high lipid burden is the troublemaker and is jeopardizing the success of our PCI. So I think that is another piece of the puzzle that fits very well into the discussion.
One additional point is if we have to interpret the OCT as a technique in opposition to functionality, I think that is a wrong way to use. I think this is valid for IVUS and for OCT too. What we are trying to do is learning how morphology and functionality can be combined and used in predicting. So when you was mentioning, for instance, the value, the predictive value for the future outcome of the patients of a no flow limiting lesion, I think I was already demonstrated that depending upon the type of plaque, you can predict the evolution. And when you have a thick fibrous cap atheroma, the prediction is much more reassuring compared to the thin fibrous cap atheroma. And so if you have intermediate lesion or no flow limiting lesions in which you can understand the morphology and functionality together, so I think that the prediction can be even more significant. So I don't want to put in a battle morphology and functionality as was done until now. I think they have a specific contribution that we are trying to clarify, getting data.
I think the physiological assessment of the lesion and the anatomical assessment is complementary. It is not the competitive method, yes, but physiological assessment, they get the class 1 recommendation in the guideline, but the intracoronary imaging is still class 2A, as you know. Are there any good idea to get a class 1 recommendation in guideline in OCT? Are there any good recommendation?
Time.
Time.
For being 1A, they need 21 years. And I think that this is what we needed, to have time and collecting data.
Right. So as I told in my introduction, there are a lot of pilot study at the moment, but there are no randomized prospective study to show us the advantage of OCT guided PCI or OCT assessment in the coronary artery morphology, right? So we have to do the randomized prospective study in large number scale. You agree?
Of course, yes.
Okay. So we discussed about the advantage and disadvantage of OCT versus IVUS, but there are already enough data about the OCT guided PCI, but it's only the pilot study. We have to do the future evaluation by the randomized prospective large number population. At the moment, that is the conclusion in OCT in the clinical daily practice. If you have another comment, please. If not, I would like to close this session, right? Okay, thank you very much.